Well, good morning. It's wonderful to be here and have this opportunity to present at the 2024 Georgia Commission on Women Wellness Summit. My name is Sonu, and I am an academic physician by way of Emory University School of Medicine, Children's Healthcare of Atlanta, and Grady Memorial Hospital. As mentioned in my bio, I have had a long-standing interest in the connection between childhood adversity and all sorts of different health outcomes. And as my work in this space has evolved over time, I would say my perspective has really been broadened to topics beyond childhood adversity, to thinking about bigger questions related to living well and the idea of flourishing. What are the inputs of flourishing? What do we know from the research about human flourishing? So, in light of the theme of our conference, which is health in action, I am delighted to be able to share with you some thoughts that can help us not only in the work that we do for others, but for our own lives as well. Now, when I first learned about trauma, this whole topic in 2015, it absolutely changed the trajectory of my career, but more importantly, it made a tremendous impact on my own life and in my closest relationships. Really, as I learned to understand and make sense of my own story. So my hope is that as we move together through this topic today, that something will resonate with you, that will be that nudge, perhaps, that you've needed to think about and pursue your own healing and journey of self-discovery. Now, as I mentioned, the theme of today's conference is health in action. And certainly through this presentation, there are going to be many thoughts you'll have with respect to action steps. I hope that that's what happens. But before we rush to creating a kind of checklist of task or action plan, my ask of us is really just to be present. If your schedule is anything like mine, you are constantly moving from one thing to the next, and it can be pretty hard. It can be pretty difficult to find time for rest and contemplation. I hope this hour can provide that space for you. So for the time that we have, my request for us, my humble request is for us to just be. This is a time, think about it as a way to check our own emotional and mental vital signs. The truth is, the work of caring, to do the work of caring and serving our patients, our clients, our families, it really doesn't require more than who we are. And the thing about it is, what gets in the way a lot of times of being able to show up as we are and meet people where they are the layers of stress that we're dealing with, coping, self-protection, the ways that we numb out, or the ways that we just crawl by or get by, that we get so used to that after a while it feels like there's no other way to be. While I'm going to be sharing about how adversity shows up in children, adolescents, and adults this morning or today, this talk was equally relevant to us as it is anybody we provide care for or provide services for. So everything about adversity and flourishing is as much about our lives as it applies to the people we serve. So in this talk, I have three primary objectives. One, let's unpack the problem, get on the same page about what we know from the research on trauma and health. I know that trauma is an increasingly popular topic in popular media. You've probably seen reels on TikTok or Instagram from various, social media therapists and whatnot talking about trauma. A lot of that information is great, but a lot of it, as it sort of drifted from, into the outer valences, and it's far from the nucleus of source of information, a lot of that information can kind of be misleading. Not every experience that we go through, for example, is traumatic. Some are uncomfortable, some are distressing, but not every experience reaches that criteria or threshold of true trauma. The second thing we'll talk about is what's happening in our bodies. Let's talk a little bit more about the physiology or the physiologic changes in response to these experiences or exposures to trauma. And I think that's interesting because that really solidifies the fact that this connection between trauma and our health is real. It's not a fad and it's not going to go away. We can't just turn a blind eye to it and expect that we'll talk about something else in the next 5 years. What we've learned about trauma is here to stay. And this second point, we'll talk about that. And then third, we'll dive into some aspects on what we can do in response to what we've learned from the research on trauma, from traumatology or trauma science research. And in that section, I will highlight one framework that I think is really useful called trauma informed care. You might have heard about it in other presentations, but my take on trauma informed care is really informed by how we care for patients at the bedside. And so I'm hoping that something there will connect with you as well. So let's jump in and talk a little bit more about the problem. What is this connection? What have we learned about trauma and health? Well, let me start with a quote that I you know I have a dad joke. I cannot resist saying this dad joke, but so I have to say it this time. It was said by Dr. Bob Ross, not the painter, but the pediatrician. Um, okay, now that I got it out of the way, the quote is: some years ago, Dr. Ross said, as he was leading this large endowment in California, the California Endowment, he observed that of all public health issues that are important for him, especially from where he sat, that childhood trauma is the number one public health crisis. But not only that, it's a public health crisis that is often hidden in plain sight. And I love this quote because it captures the most insidious aspect of trauma, that it's a problem that is hidden in plain sight. And when it does show up, it often comes out as behavioral reactivity uh, or dysregulation, which we in the public often label as, oh, that person is just, a person of bad character, or what's up with them? What's wrong with them? When a lot of times what we're missing is what's happening underneath the behavior that is creating the pressure for that person to react in this way. When you start to understand the narrative of trauma from a bird's eye point of view as well, you start to appreciate how much our society has actually normalized trauma and to this day continues to fail to meet people where they are. And so bit by bit, I'm hoping that as we get more informed about trauma and how it shows up, how common it is, how normalized our society has made it, that we can discern better and respond more compassionately with greater empathy and kind when we notice that someone is having a trauma response or dysregulated. I want to anchor this talk with a patient case that might be relevant for this audience. So I'll just dive into it. We have a patient, and this is I would say a real life collection of patients in one person. But each of these components are real life examples. So I've called this patient Ava. She's 12 years old. She's at my clinic for a checkup. She's with her mother. She was formerly a straight A student and loved to swim, but over the past 3 or 4 years has struggled in school, has gotten into fights, has been suspended a few times. And as time has gone on, she's been increasingly withdrawn from her mother. She has these really drastic mood swings. She's always on her phone, social media. She's staying out late. Her mom feels increasingly disconnected from her and she doesn't know what to do. Her mother is now concerned about ADHD, which was never a concern prior to 4 years ago. And her mother also suspects that Ava started dating an older teenager, but isn't sure because Ava really isn't talking about it at this point. Now, let's pause there. We're going to come back to this case in a little bit. I do want to tell you a different story that is, I think, a really good primer for why this topic of trauma and health is such a paradigm shifting concept. So I call this story Smoke or Fire. If you come back with me to the mid 1980s, and this is when I was born, 40 years ago, my goodness. We're in San Diego, California at a Kaiser Permanente. And at the time, at Kaiser Permanente, there was a physician by the name of Vince Felitti who was in charge of running a weight loss clinic that was actually really successful. Men and women would come in, they would lose weight, and they were able to keep it off as long as they stayed in this program. So, what he noticed, though, despite the program's effectiveness, was that over a period of 5 years, about half the people just left the program. And what made him uh, even more confused was that the people who left the program were more likely to have lost a substantial amount of weight or have reached their goal weight when they left. Why would people leave a program if it was delivering on what it was set out to do, what its intention was? So, being the very curious person that he still is today, he conducted a series of interviews with as many former participants as he could find. And it just happened to be that through one woman's story, he stumbled upon something that was completely unexpected, something that he didn't learn about in medical school. Neither did I, by the way, but something that radically changed his perspective on what was happening, what could explain the obesity, the prevalence of obesity that he had been observing. So while in the program, this woman he interviewed went from being over 400 pounds and got down to about 130 in less than 2 years. And when she achieved this weight of about 130, suddenly she disappeared. And several weeks later, she comes back having regained almost 40 pounds. And when he interviewed her, she shared that a coworker, an older gentleman, had made a sexual proposition to her. He had hit on her. And this unexpected solicitation triggered for this person these long buried memories of when she had repeatedly experienced sexual abuse and trauma between the ages of 8 and 12. It was during this period of abuse at this age, at this young age, that she began this pattern of binge eating. What she noticed, later on, what she reflected is that the binge eating actually helped her to feel better. It was a kind of self-soothing activity. But what she noticed, what happened subconsciously, which she only could notice years later, was that eating and gaining weight became a way to protect herself and go unnoticed, fly under the radar from other potential predators. Dr. Felitti had never heard anybody talk about weight gain or binge eating in this way before, as it was a kind of protective mechanism. So he went back to his team and he instructed them to ask everyone they could about their histories in childhood, especially if there was a history of sexual trauma. And what they went on to discover was that almost 60% of the people in the program who had quit had a similar history of abuse, and that sexual trauma was disproportionately more common relative to the general public and relative to those who remained in the program. So the key lesson for Dr. Felitti and his team, the kind of aha moment or the thing that allowed them to see the forest for the trees, to have that perspective that was missing, was that what we often label in healthcare as the problem, which in this case is obesity, was in fact the solution or signal for his patients or the people he was caring for. The problem, which we call, or the thing that we call a problem, in this case, was a defense mechanism, an adaptive survival skill, but one, of course, that comes with serious health consequences. And we can replace the problem. It extends beyond just obesity. We can also replace that with substance use disorders or other types of health risk behaviors or risky health behaviors that often in healthcare we're like, if you just quit this, then your life could be better in so many other ways. Why can't you just quit this? And as it turns out, a lot of these behaviors or activities we label as problems, um, there's more to the story than we can realize. As it turns out, as we'll see shortly, maladaptive behavior is a very common phenomenon in how we individually deal with the consequences of adversity and trauma. And in this small scale study is what inspired and led to the development of the landmark adverse childhood experiences study, which I'll talk about shortly. But the reason I call this story "Smoke or Fire" was from this quote by Dr. Felitti. He said that obesity, though an obvious physical sign, was not the core problem to be treated any more than smoke is the core problem to be treated in house fires. So my thought-provoking question, you could say, as we go into the rest of this talk is, in the work that we do, in the work that you do, what do we want to be doing? Do we want to be putting out smoke, or do we actually want to be putting out fires? Now, one person, after I said this, some years ago, asked me, "Well, doc, smoke inhalation is not good for us either, right?" And I was like, "Touche." So in some ways, we have to be addressing both. But I think my point stands that if all we do is try to wave around the smoke, try to clear out the smoke from a house fire, but never actually get to the fire, we're going to be putting out smoke for forever. And so I think we do need to turn our attention more upstream, thinking about how can we actually prevent these fires from developing in the first place, and how can we effectively put them out. So, as I mentioned, that small study that Dr. Fleety did from his weight loss program inspired what we call the ACE study today. Now, this is a landmark public health study that has revolutionized our enthusiasm in studying trauma. It's been cited over 12,000 times in popular media, I think over 6,000 times in academic literature. This is not a new study. It was published in 1998, and so participants were recruited in the mid-90s. It lasted formally for about 10 years, but it's still ongoing today, at least through Kaiser Permanente. They are still collecting data on their patients. And as you can see there, it was a joint effort by the CDC, the Centers for Disease Control and Prevention in Atlanta, and Kaiser Permanente in San Diego. Now, what these researchers did was they asked over 17,000 adults who were all participants in the Kaiser Permanente San Diego location, and they asked these adults about 10 different categories of adversities experienced specifically within the home. And these adversities, you can see there on the screen, spanned 3 domains of abuse, neglect, and household stress. Now, of these 17,000 adults, 75% were mostly white, 75% had attended college, and 100% were insured. And so altogether, this participant sample was quite affluent with respect to other research samples in that day and in present day as well. A lot of people said that, this is actually a weakness of the study because it didn't include the broad diversity of people that exist in the general public. But for me, I would say, well, hold on a second. I think it could actually there's some strengths to this design, even though the researchers didn't intend to make this point. Why could it be a strength? Well, it's because of what they found, that ultimately the ACE study showed that adversity in the home is way more common than we realized, even for people for whom society might assume are just doing fine. The story of adversity, turns out, is not something that anybody should or can feasibly create distance from. In many ways, it's our story just as much as it is the people we serve and care for. Now, as I mentioned before, the ACE study ran formally for about 10 years in partnership between the CDC and Kaiser Permanente, and it generated several dozens of research papers. I think 80 to 90 was the last count I had. Of these 90 papers, I want to condense what they found into three key findings. The first one, and we cannot skip over this, we cannot diminish the importance of how groundbreaking this finding was simply that ACEs are common and they cluster together. How common? Well, again, in this mostly white, mostly middle class and college educated and insured group, 64%, almost two out of every third person, had one or more ACEs. So they just simply quantified the number of ACEs each person had. And so trauma from these data is not just a problem that we can attribute like society tends to do as something of those people, however you want to define that. We know from this study and several others since then that ACEs actually occur across every race, ethnicity, income level, community, geography. Uh, Now, with respect to patients at Grady, where I work clinically, collectively, there is a very, very high prevalence of trauma. Some years ago, they did a, uh, a different kind of ACE study. It wasn't exactly the same as the original one, but what they found, they asked about a fewer number of ACEs, and they still found that the prevalence of people having one ACE or more was almost 90%. And then looking at Georgia more broadly compared to national data, we've learned in recent years that while the overall prevalence of Georgians having one or more ACE, which is represented in the blue there to the right, or the purple to the right, while it's similar to the ACE study at around 60%, I'm sorry, the blue, all the colored slices there represent one ACEs or more, and the gray represents zero ACEs. While the prevalence of one ACE or more in Georgia is similar to the ACE study at around 60%, the prevalence of having four or more ACEs actually might be higher in Georgia, where it's 18% versus 12.5 or 16% in more recent data. So ACEs are common and they cluster together. I'll mention real quick the clustering piece. If a person had one ACE, they were about 90% likely to have two ACEs or more, and about 60% likely to have three ACEs or more. So it was actually less common that a person would just have one ACE and that's it. If a person had one ACE, they were very highly likely to have another ACE or more. The second key finding, and this is what just had my jaw on the ground the first time I heard about it. I remember being cynical. I remember being in disbelief. How do you know? And so I read as much as I could about ACEs. And after doing lots of reading on the ACE study and other related studies, I am completely convinced that this association is real. It's been replicated many, many times. And it's really telling a story that we have to pay attention to. And the point is that ACEs are associated with a multitude of undesirable health, behavioral, and social outcomes. What are some of these outcomes? Well, we know through the 10 years of the ACE study and other research related that ACEs increase the risk for things like health risk behaviors, which include behaviors like smoking cigarettes, early initiation of smoking in early adolescence, alcohol use disorder or alcoholism. This also includes early initiation of alcohol in early adolescence. ACEs also increase the risk of other types of drug use, especially IV drug use and opioids, and high-risk sexual behavior and teen pregnancy. Additionally, ACEs increase the risk of mental health problems from childhood through older adulthood, which include the most common ones like depression, anxiety, and PTSD, but also suicidality and hallucinations. I would also add here schizophrenia, bipolar disorder, etc. ACEs also increase the risk of chronic disease. And this is one of the areas that I was most cynical about. What they're saying here is that things that we experience in childhood can actually have an implication on our health in middle adulthood. And these associations have been borne out and replicated and repeatedly observed over and over again, not just within the ACE study series, but other research designs and other samples as well. The chronic diseases that have been most attributed or most highly associated with ACEs include things like cardiovascular disease, heart attacks, um, or other sort of valvular heart diseases and heart complications. COPD or chronic lung disease is also very common. Cancer, non-skin types of cancer, to be more specific, diabetes, obesity, sexually transmitted infections, autoimmune disease, and liver disease. And then finally, they also recognize that it's not just these traditional health domains that are implicated with ACEs, but there are other more socially relevant uh, outcomes that are also disrupted or related to ACEs in a negative way. So we've learned that ACEs are linked with people's own perception of their health, poor self-reported health. They're associated with disability, mortality, unemployment, and financial stress. And while I've talked through a lot of outcomes here, I would stress again that these are just a sampling of the outcomes we know about. This is a table that I'm not showing with the intention that you would read every line. I just wanted to give you a sense of the breadth of outcomes that have been found to be associated with ACEs. Most, if not all, of these associations have what we call a dose-dependent relationship, meaning the more ACEs a person has, the higher risk of a given outcome. And so you can see here that it's not just one particular type of disease that is represented, but really ACEs are impacting us holistically in a global sense. This is a slide, this table is just showing adults over here. The next slide is some similar, or there's some overlap in these outcomes, but specific to children in pediatrics. So these are not just outcomes that skip over childhood and manifest in adulthood, but we can actually observe the effect of ACEs actually going back to the earliest of childhood outcomes and developmental milestones. So in this study here, we can see that ACEs are associated with developmental delay, and this is developmental delay in general, which includes things like language and speech, social milestones, social interactions, gross motor skills, fine motor skills, sensory processing. And this is to the extent that for those young children who have had 7 or more ACEs, almost 100% of them were found and observed to have some kind of developmental delay. ACEs increase the risk for academic vulnerability. And this study found that after adjusting for which school the child is attending, their grade level, their race, ethnicity, gender, socioeconomic status, or even after adjusting for whether they were in special education, children with 4 ACEs were at a much higher risk for things like academic failure, having attendance problems, and having behavioral problems in general in the school. So what we see from this study is that ACEs don't just impact a child's academic potential, but it also affects their ability to stay regulated in school. And interestingly, it also affects their attendance, the regularity by which they attend school. Another school-based study found that those children with 4 or more ACEs are at a whopping 33 times greater risk for having some kind of learning or behavioral problem like ADHD or oppositional defiant disorder. And this is compared to children who have no ACEs. Now, while the original ACE study only included ACEs that occur in the home, within the 4 walls of a home, things like abuse, neglect, and household stressors, we also have to acknowledge that there are many more types of adversities and traumas that are important and occur outside the home. And so I like to use this tree, which we call the tree of ACEs, to illustrate this point. Here, the leaves and the branches of the tree represent the 10 conventional ACEs that we just talked about. And you can see those are abuse, neglect, and different household stressors. Again, these are the ones that occur in the home. Now, every tree grows out of a trunk with many roots. And so here, the roots are what we call adverse community environments. These include things like poverty, violence in the community, racism, discrimination, economic disadvantage. In and of themselves, all of these are adverse events. They're also independently linked with poor health outcomes, but they also provide a kind of context or pressure out of which those leaves and branches, those interpersonal ACEs, occur at a higher frequency or a higher severity or in the absence of a helpful resource. And this is a phrase that I borrowed from Laura Porter, who is a thought leader in this topic of ACEs. She said once that poverty is like pouring gasoline on the fire of ACEs. To go one step further, the health of the tree that grows out of the roots depends a lot on the quality of the soil, what kind of minerals and nutrients exist in the surrounding soil. And so we refer to the soil as adverse collective historical events. These are examples that I've included in recent history that have conferred an inter or multi-generational impact. These are things like slavery, genocide, mass incarceration, Jim Crow, the Holocaust, forced displacement, COVID, what's happening, the war in Ukraine, the war in Palestine right now. These are studies that have shown there are several studies that have shown that trauma can actually be inherited across generations, and we can measure this through changes in a component of our cells called the epigenome. So I won't go into that today, but the main thing I want to stress here is that when we talk about ACEs, we can't really separate the conversation about ACEs apart from injustice and inequity. For me, it's really important that we maintain that link together, because if we only look at the surface level problems without understanding the history behind it or underneath it, we're really missing opportunities for understanding, but more importantly, we're missing opportunities to actually correct course and achieve equity in a way that humanizes people and is collaborative and supportive and like I said, understanding overall. Now, I know one of the pillars of the Georgia Commission on Women is human trafficking, so I wanted to include some information related to this topic specifically as it relates to ACEs. So there is one paper that I found from the American Journal of Public Health that asked this question: what is the relationship between ACEs and human trafficking, specifically within minors in Florida? And what they found, perhaps to no one's surprise on this call, was that there is a substantial relationship between ACEs and being a survivor or victim of human trafficking. Sexual abuse is by far the strongest predictor of human trafficking. But you can see there's actually quite a strong difference between gender. Girls are 2.5 times at greater risk for human trafficking with a history of sexual abuse, but boys are over 8 times greater risk. Additional relevant ACEs that increase the risk of human trafficking, being a victim of human trafficking within girls, it's emotional and physical neglect, a history of family violence. And for boys, interestingly, the signal that came up was emotional abuse. This is a study that shows in graphic form, again, with the sample of juveniles who were involved in the juvenile court system. And you can see here in the orange the prevalence of ACEs in these these young people who were in the juvenile system. And in the blue are the prevalence of ACEs in the original Kaiser Permanente cohort. And you can see it's almost opposite, where if you look in that 4 or more category, as I showed earlier, about 12.5% of these adults in the Kaiser Permanente study had 4 or more ACEs. Look at the difference in the juvenile offender group, that it looks like 50% of them had 4 or more ACEs. Now, building on that, there's another study that found, and this is from the CDC, that among ACE study participants, those with higher ACE scores were at higher risk for sexual re-victimization in adulthood. And there was a dose-dependent relationship between ACE score and re-victimization. So if we step back for a second and just try to digest what we've been through, I hope what becomes clear is that this experience of trauma for a lot of people is not just an experience or like just a part of their past. But on the contrary, the experience of trauma, of unmitigated adversity, can be utterly devastating across multiple domains of well being and functioning in our society. I know we've heard a lot. Some years ago, there was this phrase, we have this school to prison pipeline, but I would argue that the problem is bigger and it starts earlier and it has a historical precedent. What we're not seeing is merely this school to prison pipeline. What we're seeing actually is an unaddressed trauma to prison pipeline. And school is just a touch point along the way where we're recognizing there are problems. And as a society, if I can speak bluntly for a second, we've actually criminalized, we've opted to criminalize and jail and imprison victims of trauma, trauma that no child or teenager ever asked for in their life. So let's go back to Ava. We mentioned before, Ava is here for a checkup, and she was formerly this bright student, but in the past 4 years has been struggling. And so I hope after what we've sort of gone through, we're wondering, okay, why? Like, what's happening? What has happened in Ava's life that led to this change? I hope we're getting away from the idea that Ava just suddenly doesn't care about her future, or she only cares about her friends, or she wants to disrespect her mother. I hope we sort of can pick up on that sense that, oh, something actually happened in her life. Well, as we learn more, as we talk to her, we find out that about 5 years ago, when Ava was 7, her parents separated because her mother was being abused by the father. Was being abused. There was intimate partner violence going on, and so, excuse me, the father is no longer in contact with the family, including Ava. Mom has never talked to Ava about what happened with her father after her father left. They just kind of stopped talking about it and buried it and tried to move on. Mother, she is working 2 full-time jobs and she's struggling to make ends meet because of the separation. And they're at risk of moving again. And the mother expressed that she was really, really stressed about this. On top of that, the mom is dealing with her own health concerns. She has severe depression. Her anxiety has gotten worse. She's been drinking heavily at night and thinks that Ava doesn't know about it. She thinks she's been able to sort of keep that compartmentalized from Ava. Separately, when I talk to Ava, she reports regularly skipping school, vaping, drinking in cars with older teens, and she felt alive when she shoplifted for the first time the other week. She says in passing, really, Doc, the only good thing in my life right now is Ron. All right, we'll come back to her shortly again after we move through this next section. So we just spent a good chunk of time unpacking this association between trauma and health. Now I'd like to jump in, dig in a little bit more into asking the question, like, how is all of this happening? What is driving this relationship, this connection between adversity and all of these health outcomes? As it turns out, in the past 3 decades, with the advent of sophisticated brain imaging technology, with advances in research and child development, even sociology, anthropology, there's been this incredible convergence of research from multiple fields, again, from neuroscience, psychology, medicine, public health, child development, anthropology, all around understanding how stress and trauma affect our brains. Turns out the brain is the central component, it's the organ that is most impacted from unaddressed adversity or trauma. I love this quote from Doctors Perry and Ludi Dobson. They said that understanding the power of traumatic events to shape the brain helps us better determine what a child needs to heal. I think this quote is so spot on because if we want to promote healing, we have to understand how these experiences affect our brains and the way our brains function. So I want to just give us 4 fundamentals things to know about developmental adversity and the brain. This is kind of a crash course in interpersonal neurobiology. The first, most important thing to know is that fundamentally, when we are born, we are ready for connection. You could say that we are neurobiologically wired for it. What do I mean by that? Well, if all we do after a baby is born is feed the baby, change the diaper, and then try to put them to sleep, that baby will not thrive. Babies need, in addition to their physical needs being met, they need emotional connection and relational connection consistently in a safe, stable, nurturing way over time. Why is that so important? Well, the research has shown that when babies are in that kind of environment, especially in the first 5 years of life, it is fertilizer, it is powerful fertilizer for optimal brain development. We do best when when we have strong relational connections with our caregivers and other consistent adults in our lives. The second thing we have to know is that while we can't change the genetics we're born with, experiences shape brain architecture. Positive experiences and negative experiences both influence brain architecture. And if we influence the way that the neurons form and how the brain architecture is sort of unfolded over time, it's going to impact circuitry and therefore function over the life course. Third, we don't like trauma at any age. At any age, it's not great. It's bad. But the earlier it occurs, the more cascading its effect, the more widely the development can be disrupted. You remember that slide that I showed earlier about developmental delay in adversity. So if we know that early life stress has the greatest impact on child development and well-being, this should push us to think about interventions that occur earlier in a child's life, or better yet, before a child is even born and a couple or a person is thinking about having children. Lastly, toxic stress. There's this idea of toxic stress, and that qualifier word toxic is really important because what it's saying is that not all stress is bad or equally bad, but there is a kind of stress environment that can reach toxic levels that is particularly devastating to healthy brain development. One way you can think about toxic stress is it's kind of a hijacked stress response system that doesn't respond to normal feedback mechanisms. What we learned about this thing called toxic stress is that it can disrupt healthy brain development. It can dysregulate our normal stress responses, which I'll talk about in a second. And in so doing, it can derail healthy socio-emotional development and show up in problematic or challenging behavior, which often represents a dysregulated state. One of the most important pearls that I want to leave you with in this section, and this is kind of like the elephant in the room, and this is one of the most important things I've learned from this research, but also one of the most difficult things to remember and implement in my daily practice. This is the key. The behaviors that stem from how a child survived or coped with adversity or trauma are actually normal or predictable events in the sense that they are adaptations. They are not inborn personality defects. Now, please don't get me wrong. This is not a plea to, excuse bad behavior or undesired or negative behavior, but it's a way for us to understand better what is happening when we see that child or client or parent who is dysregulated. Maybe you see it in public. Maybe you see it at the grocery line when someone has been waiting too long and they just start losing it. Or maybe you see it in traffic in the form of road rage. But understanding these dysregulated behaviors is so important because what it prevents us from doing is saying that person is just bad. Instead, we can reframe it and say, there's something that happened in that person where they're just beside themselves and not regulated right now, where we don't judge their character or person, but we think strategically or empathetically, how can I help this person reestablish regulation? let's talk about stress for a second. How can we understand what's happening on a physiologic level in response to adversity? There's been a lot we've learned about trauma through understanding our brains and how our brains and bodies respond to stress. One heuristic or approach to this that I'm a big fan of is polyvagal theory, which organizes how all this works in a kind of digestible, accessible way. But my caveat to this is just one way of describing an incredibly complex phenomena of how our brains handle stress and adversity and trauma. So it's purposely simplified. So, with that being said, before civilization, if you and I are still living in as hunter gatherers and we're in a clan, our bodies needed an efficient, fast acting stress response to survive threats. So if we were out in the woods and we came across this animal, this bear, instantaneously, our bodies would need to be able to kick into high gear to survive this, let's say, mama bear who feels threatened that we're too close to her cubs. And so, what happens in our bodies, well, actually, starting with our brains first, is that once our brain recognizes, hey, this is a life threatening event, it activates the smoke alarm center of our brain, which is called the amygdala. And the amygdala, in turn, sends downstream signals to activate our stress response system. Our stress response system is composed of two primary systems, the sympathetic nervous system and this thing we call the HPA axis, which stands for the hypothalamic pituitary adrenal axis. This is where this is sort of how cortisol, which is a stress hormone or stress steroid, becomes elevated in our bodies in response to stress. So as the stress response system is activated, and as it activates the sympathetic nervous system and HPA axis, it leads to the release of many endogenous stress molecules that our own body produces. And these molecules then act on our organs and change our body's physiology. And they promote things like an increased heart rate, they raise our blood pressure, they help our airways to dilate more, to increase the surface area, to better exchange oxygen and CO2. There's more oxygen delivery to muscles. On the flip side, blood is shunted away from our gut system because when you're trying to survive a life-threatening situation, it's not the time to have a bowel movement or need to stop and pee. But the point here is that in response to a perceived threat inside all of our bodies, these steps occur. But the output or the action of our stress response is variable. Some of us, as we're together, might think, I have a better chance if I fight this bear because I can't run away and survive. Others of us might think, there's no way I can fight and win. I got to run away. That's my best chance. There's a third response that is particularly common in children, especially if let's separate our the example from bear for a second, but especially if the abuse is coming from in the home where they cannot fight the perpetrator and win and they cannot run away and survive. The third response is to stay put and freeze, where the brain dissociates. And in that dissociated response is actually an extremely intelligent protective mechanism that can actually help a person survive even these kind of life-threatening situations with a grizzly bear. Now, over time, the brain automatically takes inventory of which responses have worked and which haven't. And the ones that work can become crystallized into predictable behavioral responses that can emerge involuntarily underneath our awareness whenever the brain perceives threat. So, for example, if the fight response worked for the person when they were a child, let's say that they got really angry and it neutralized the threat, the brain is going to remember that and may bring that behavior out non-specifically in future situations when that individual, as a teenager or as an adult, feels threatened. What you might see is a sense of, in response to a stressful circumstance, in an interpersonal conflict, you might see hypervigilance emerge, or rage, irritability. Another example, if fleeing or the flight response worked, you might see avoidance behavior or also anxiety, hyperactivity. And then if neither of those things worked, you might see the behaviors related to dissociation, depression, exhaustion, numbing, as reflected in the freeze response. Now, just keep in mind that this is a simplified portrayal of how the brain becomes reactive in response to trauma, because in reality, we have a blend of these responses depending on the context and what worked and what seems most likely to work in that moment. But again, what I want to stress here, what's important to remember is that these behaviors can be really problematic in public settings, but they're born out of a need for the individual to feel safe, to defend himself, to defend herself at the point of initial trauma or adversity. These are not personality features, but they are reactions that come out reflexively when an individual perceives a threat, whether it's physical or emotional. There's one more response I want to highlight here. It's called the fawn response. This is also a behavioral strategy that seems more common in modern day, in our modern society. It's where a child or adult can actually be a people pleaser to mitigate anticipated harm or distress. It's kind of like a combination of avoidance and dissociation. By being accommodating, which often can show up as like walking on eggshells, the individual can sort of safely avoid threat. And of course, this can be problematic in other social settings because it can appear as if a person is just like laid back, doesn't care, or maybe says one thing and does another. It can be really confusing, especially for health providers, because a patient may want to not disagree with me, but not feel comfortable with a treatment plan, and then go home and not do anything that we talked about and agreed about. So just another one I wanted to mention there. Now, real quick on toxic stress. I'm really summarizing decades of convergent research from multiple fields, but the bottom line with toxic stress is that ACEs can be a cause of toxic stress. This is the kind of stress that's so severe that it can disrupt brain development, brain function, and brain growth even. Toxic stress, again, is different from your day-to-day stressors like preparing for an exam or first day at a new job, or even more discrete ones like car accidents or if you had to spend the night in the hospital for some reason. Toxic stress is caused by a stressor or series of stressors that are prolonged, unpredictable, unrelenting, outside of that person's control. And the last piece is important, inherently in the absence of protective relational buffers. When toxic stress occurs during a child's development, which is most important and rapid in those first 5 years of life, that's when it can confer the most harm and most damage. And I showed this earlier, and I just want to reiterate the point that these behaviors that we often see, especially when we're interfacing with patients or clients in a very dire moment of need, these behaviors are not personality features, but they are behavioral reactions, again, that are coming out because they worked at some point in that person's past. The challenge for us, especially if you're in healthcare, is that inherently, when we meet people in the hospital or if they're coming in for a sick visit in the clinic, we're meeting them in a moment where their threshold for a behavioral response like this, reaction, their reactivity, that threshold is lowered. And so a lot of times we can kind of fall, if I'm just speaking for those of us in healthcare, maybe this can relate to anybody who's working with human beings really, but a lot of times we kind of slip into this mode where we think that our patients should be kind, that they should be regulated, that they should be able to deliver a history to us in a coherent manner, when we know that the truth is far from that. We have to recognize we are meeting people in a moment of need, of high stress. When they're coming to the hospital, that could be the worst week or worst day of their lives. And so in a sense, what I tell my teams on the wards is, hey, we actually have to expect some level of behavioral dysregulation And we should actually be surprised by kindness, compassion, and regulation because when we see that, that means that person is working really hard to make sure that they're on the same wavelength with us and communicating with us. But for the most part, let's let people be people and try to meet them where they are. Okay, I know I'm at the hour mark. If you got to go, I understand, but please hang with me if you're able to, because I did have another 15 minutes or so to I wanted to spend to talk about this third section. How can we respond? What can we do with everything that we've just unpacked in the past hour or so? And I'm here to say really good news. Adversity is not destiny. I know we've talked about a lot of hard things, hard truths, but the reality is we actually have many reasons to have hope because certainly ACEs and trauma are not the end of the story and they're not the end of our stories. Here's the thing. We all know people, or we know that not everybody who's experienced trauma in their childhood is doomed to these negative consequences. We all know people in our lives. It might even be you who's watching this presentation at home who have made it despite the odds. Life is not perfect. It will never be, but our past experiences don't have to have power over us in the present. So, what is it about people who are able to live that healthy, adjusted life despite having high numbers of ACEs? Well, what it all kind of boils down to, and what decades and decades of research have consistently found, is that the most important factor to promote healthy brain development, but also to recover from trauma long term, is for every person, every child to have a safe, stable, nurturing relationship with an adult caregiver if you're a child, but with other peers, your family, close friends in adulthood. The answer is not medication alone or technology or some kind of fancy program. It is simply the committed presence of a loving and engaged person or adult. Again, if we're talking about a child, this is the game changer. We call these safe, stable, nurturing relationships. SSNRs, this is the irreplaceable starting point for every child. It's our best defense against a world that's full of uncertainty and trauma. Whereas adversity makes us vulnerable, healthy relationships actually protect us because they help protect the brain. And so every intervention that we do out of this should actually be grounded in this understanding of the importance, the critical importance, the centrality of supportive, nurturing relationships. This is the nucleus upon which everything else should be built around. Safe, stable, nurturing relationships help build this trait called resilience. And I want to pull this topic back, pull this concept back away from the corporate world where they just like tossed around resilience like it's just like, burn out this and resilient. Resilience is a very, very important and invaluable topic when it comes to trauma, because this is the trait that we want to see that is so protective that it can prevent future trauma, but can actually help a person navigate potentially traumatic experiences without succumbing and developing negative health outcomes. The two things that we have to know about resilience is that it's not something that anybody is born with or develops in isolation. Resilience is built, it's cultivated through the type and the quality and number of positive adult relationships or a child's social ecology. But in adulthood, it can also be strengthened or reinforced as well. But it makes no sense to tell a child, hey, be more resilient, as if that's a thing that a child can do by themselves. Resilience is, again, it's cultivated through that social ecology. And I mentioned before, resilience is important because when it's present, that means that even in the face of high ACEs or trauma, that person can still find ways to adapt in healthy ways and succeed. The reason resilience matters on a neuroscientific level is because resilience is that which can promote healthy neuroplasticity. Neuroplasticity is the ability for the brain's architecture to change in response to a stimulus, whether that's an external stimulus or an internal stimulus. And as I mentioned earlier, just as negative experiences can alter our brain's architecture, so can positive ones. And so we just call these behaviors that we want to see in response to social connection, we just call that resilience. But please don't, you know, please don't hear me wrong. That I'm not saying resilience is the only thing that matters. That when we start to have that conversation, we can easily get into, well, what about the system? And what I'm here to say is that both need to be thought of, both need to be considered. But resilience as a trait in the trauma literature is extremely, extremely important. The hopeful thread that's been observed repeatedly in the research, in the resilience research, is that the weight of protective factors, which I'll show you a list in a second, far exceeds the weight of ACEs or trauma. It's like our brains and our bodies are predisposed not for sickness or illness, but we're predisposed to resilience because that's how much protective factors matter. Even in the face of adversity, research says that we know children can flourish if the family holds certain features or can develop certain features of resilience. So, what are some examples of these critical factors that support building resilience? When the center here, like I mentioned, is safe, stable, nurturing relationships, but things like supporting parents and parental resilience is exceedingly important. The importance of being socially connected, of and this is why things like screen time and isolation are so toxic to child development. We do better when we're more connected with others. Providing concrete support, housing, rental assistance, utility assistance, legal support. When a family needs that, when we provide it, that also promotes resilience. A big one is informing and educating parents on normal child development. A toddler cannot tell you what 2 plus 2 is. They might in a few years, but that's a simple example, and I think most people can understand that. But a lot of times we think that a toddler should be able to regulate their tantrums, but that's not an age in which the brain has developed to the extent that it can do that in a healthy way. If we tell a toddler to suppress their tantrum or stop the behavior or fix it, what we're actually doing is telling them to suppress their emotional reality. So there are other ways that we can think about helping a child who's having a tantrum, but the more we know about expected child development, the better we can approach that in a healthy, supportive way. And then supporting the social and emotional competence of children. I think this one has the potential to break intergenerational cycles, because if you're like me, if you're around that 40 to 50 age right now, a lot of us didn't grow up in homes where we had parents asking us what we thought, how we felt, or much less cared about what we thought or how we felt about a certain situation. So we grew up being used to not tending to that part of our lives, of not really respecting the emotional realities that we have. And so a lot of us, even to this day, can be quite uncomfortable with knowing how to express an emotion, knowing how to name what we feel. And all of that could actually be improved upon with intention, support, things like therapy and meaningful conversations. But if I were to give anybody a sort of a starting point list of ways to support resilience for their family, for themselves individually, I would say focus on what's on the screen here. The bottom line is that ACEs are a risk for negative health and behavioral outcomes, not a guarantee. Secondly, the absence of ACEs actually does not guarantee flourishing or well-being. This raises the importance of what we call positive childhood experiences, or PCEs, like those family protective factors I just showed. PCEs are so important because they have a threefold benefit. They can prevent ACEs in the next generation. They can protect against the effects of ACEs if they've already occurred. And PCEs, positive childhood experiences, healthy relational connection, is the secret sauce in how we promote flourishing. And I would argue that if you're working in the human service system, if you're working in healthcare or social services, that really the goal that we want to see in the people we work with and care for is flourishing. We don't want to just remove illness or mitigate disease or disease outcomes. I want the people I care for to flourish, um, and to promote that requires promoting positive childhood experiences. All right, so let's go back to Ava. We learned a little bit more about her history and can get a sense that, wow, a lot of what Ava is going through is actually indirectly related to what her mother went through. That started with this fractured relationship with her father, who was abusive. And so what we did was we recognized that this behavior from Ava was not because she wanted to be delinquent or she wanted to rebel or she was just tired of her family, but that there was an underlying reason for it that very likely related to exposures of adversity and trauma. So we connected her mother and Ava. We connected Ava and her mother with our behavioral health team. We took a trauma-informed approach, which I'll talk about shortly. And we just started small. We encouraged them to just, hey, a few times a week, just eat together. You don't have to say much during the meal, but just see each other's face as you're eating. At that point in time, they were not really eating any meals together. Her mom would cook or make food or pick things up, and they would just kind of get it and separate, go back to their own rooms. Her mom, we encouraged her to establish care with a mental health provider, which she very eagerly did. She just needed a little nudge to make that happen. It was already on her mind. We asked the school to really be considerate of Ava's situation. There's a program called Handle with Care that I don't have time to explain here, but you can just Google. It's a very discreet way you can inform the school about a child without over disclosing information that could make the child feel more vulnerable. And we made them aware that Ava was going through a difficult time. I can't say at this point that every issue in Ava has been fixed, but what we do know is that after we plugged Ava into these resources and we established a healthy rapport with her mother, that things are incrementally getting better. Ava has not been suspended. Grades are still a challenge. The relationship that she has with an older teenager is still a challenge, but they are spending more time together. They're eating together more. And so there is evidence of progress. But most importantly, Ava has expressed that she feels understood by her mother in ways that she hadn't in the past 4 years. So let me talk a little bit about this thing called trauma-informed care, which is such a valuable framework in response to everything we've learned about trauma. Trauma-informed care, importantly, is not a checklist, but it's a framework. And it's a framework that is grounded in understanding what trauma is, how it affects us, and then what we can do in response to that. The way I like to think about trauma-informed care is that it's a tool that I can use that helps me maintain a perspective or a posture of unconditional positive regard, both for my patients, the people I work with, and even myself. So what's the logic behind it? Well, the main sort of premise around trauma-informed care is that instead of approaching each other with a kind of what's wrong with you attitude, when we see dysfunctional behavior or problematic behavior, we ask instead, what's happened? Or we think instead, what's happened? So in my world, when I'm seeing in clinic the person who has, and let's say I'm in my Grady clinic, I'm seeing a person who's relapsed on drugs for the fourth time, and now their heart is really suffering the consequences from it. Or I see another person who never takes her medication for diabetes reliably, or the person who's yelling in the clinic hallway because the doctor is late or the nurse is late. And there's some part of me that wants to say, chill out. Like, what is wrong with you? Trauma-informed care is asking us to don't say that, but step back, think for a second, and ask instead, what's happened? What don't we know? Because here's the logic chain. If trauma is common, and if it's linked with all sorts of mental and physical and social health problems, if what we might perceive to be the problem might actually be that person's solution or survival skill, saying what's wrong with you reactively is actually the wrong question to ask. And it could further marginalize that person who never asked for trauma in their lives in the first place. So before I go into a patient's room, or before I go to meet a person in the hospital, uh, I will just whisper this to myself internally. And for me, it's kind of like a reset button for empathy, something I can say to myself that helps keep me grounded come what may in that encounter. There are four things that trauma-informed providers and institutions and really trauma-informed cultures will do. First, and these are the four R's. First is to realize the widespread impact of trauma, how common it is, and understand potential paths for recovery. The second R is to recognize. This is to recognize the signs and symptoms of trauma in clients, in families and staff, others involved in the system. And let me expound on this a little bit. The intent here is not to assume or judge. That's actually the opposite of trauma-informed care. But if we see behavior in a patient that signals that they're in like a fight or flight mode or freeze mode, what recognize is pointing us to is to say to resist ourselves being activated and escalating or retaliating or reacting, and then next responding with an empathetic and compassionate lens and perspective. This recognized piece is the hardest because we have to unlearn our own protective measures, our own defensiveness when we feel threatened in social situations. The last R is to avoid re-traumatization, and this can happen through really small things, like in the hospital. If I have a really stable patient who's spending the night, to try to let them sleep and to avoid unnecessary lab draws, unnecessary vital sign checks, unnecessary interruptions that will disrupt their sleep. The small things that we can do can really add up to matter. As I mentioned before, this recognize part is the hardest. But between recognize and respond is what we call the space or the pause. And I love this quote from Dr. Frankl, who wrote a phenomenal book, Man's Search for Meaning. He said that between stimulus and response is a space. And in that space is our power to choose our response. In our response lies our growth and our freedom. So what this is saying is the more, even if it's just microseconds longer, the more we can pause the next time we are interacting with someone who is dysregulated, who is yelling, when we feel that urge to say what's wrong with you, if we can pause for just a millisecond more and recognize, actually, let me not say what's wrong with you. Let me try to go with what's happened and understand that is where our growth and freedom lies. And I firmly believe that as well. Okay, so I got a couple more slides, if that's okay. And I'll wrap up. I just wanted to show you some of the guiding principles of trauma-informed care. So the four R's are kind of a process step of trauma-informed care. These are the guardrails. These principles are the guardrails that can frame our approach with people, whether we know about their history or not. So one important aspect about trauma-informed care is that we don't necessarily have to know a person's history to be trauma-informed. In fact, I sometimes, unless there's trust established, unless I have a rapport with someone, I actually do not want to ask about their trauma until I sense that they do trust me and want to share that information with me. The two things I want to highlight here are safety and trustworthiness. Safety is so important. And I want to frame this in a neuroscientific lens. So people who don't feel safe when they're in front of us or in the four walls of our building, if they don't feel safe, they're going to be less receptive to services or therapies, because feeling unsafe or vulnerable activates that threat center of our brain, the smoke alarm of our brain, the amygdala. And when the amygdala is activated, it makes input from the thinking part of our brain, the prefrontal cortex and hippocampus, less accessible. It's just what happens when you think about when you're driving down the highway and someone suddenly cuts you off. You don't sit there and think about what's happening. You're not like, "Well, that guy's cutting me off. How rude." You slam on the brakes, you swerve, you honk instantaneously. And so that's how we know that in those moments when we feel threatened, that really the thinking brain is not important to our survival in that moment. We're in that survival mode. So if a person doesn't feel safe in front of us, the same thing is happening in their brain. All that good information that we're trying to get into them, that we're trying to communicate, is not getting past their survival brain. What doesn't work when someone's upset is our efforts to be even more rational, more logical. What the person needs in that moment is a restored sense of safety and autonomy, which oftentimes means reassurance that we can be trusted. So let me talk about trustworthiness for a second. Many people who've had ACEs have had broken relationships, have been betrayed by the very people who they were supposed to be able to trust the most. So it's important that we, in as human service institutions, are committed to cultivating trust, and we don't just assume that it's there by default. So what I tell my teams is, let's go in the room seeking to earn someone's trust, not just assume it's there because of our title, but let's go into and earn their trust and show them that we are trustworthy by our demeanor and our actions. And if we can take that approach, the way we talk to someone is completely different. Okay, couple last slides, some resources that support healing from trauma. This is really for teenagers and adults. The first one is having a healthy social network, relational network. Secondly, getting specific mental health treatment. That is important to creating new pathways in our brains. Support from the broader community, especially those faith communities, I think can be a really rich resource for healing from trauma. And then having your basic needs met, social stability. At the heart of all of these guiding principles of trauma-informed care are two important things to emphasize that really support healing. It's the connection, which I think I'm belaboring the point at this point, but also agency and autonomy. So if you think about people who have experienced interpersonal trauma, who are survivors of abuse in its many forms, they have had things happen to them against their consent. And so the more that we can restore that sense of you are a person and we respect your wishes, you have a person, you have a say, you can have a say. The more we sort of uphold that dynamic, the more we can create a culture of healing. I'll just show this slide for your sake. You can pause here and do a screenshot of this, but these are some tips around how we can communicate in a trauma-informed manner, things to monitor. But basically, the bottom line here is, as we're talking to others, we try our best to stay regulated ourselves. And the beauty of that is when we are regulated, that is our true personality that is able to come out and interface and interact with others. So really, at the heart of being trauma informed in terms of communication is about maintaining our own self-regulation as we seek to be empathetic and compassionate in our interactions with others. Okay, two books I want to plug before I get to my summary is one, the book on the left by Oprah and Bruce Perry is one that I've recommended to many family members and friends. If you are looking for a read that is not super technical, but very much about the science, this is a really good one. And I've heard people really feel different after reading this book. The book on the right is by Gabor Mate and his son, called The Myth of Normal. If you're looking for how trauma has just been, how we've let trauma become normalized in our society today, this is a good book to check out. I thought it was a very fascinating read that made me kind of think differently about how we've organized our society. So let's summarize. ACEs are adverse childhood experiences that are common. They occur in clusters. They're associated with many long-term health and behavioral problems. ACEs are a cause of toxic stress, and toxic stress is that process that can lead to disruptions in brain development. Trauma often shows up not only in these discrete health outcomes, but these survival-based behaviors that, again, are not personality features, but protective mechanisms. Adversity is not destiny. Protective factors, positive childhood experiences weigh more than the traumatic ones. Trauma-informed care it starts with a very simple but profound shift of going away from what's wrong with you and towards what's happened. We talked about the 4 R's of trauma-informed care. Remember that recognize R is really, really difficult, but it's so worth spending time on. And if we can elongate that space between recognize and respond, even by just a few milliseconds, therein lies our growth and our freedom. So some considerations for applying or application of these trauma-informed concepts. Before you interact with someone you're providing services for, try grounding yourself with, it's not what's wrong. No matter what happens in this conversation, let me not think it's wrong, what's wrong with you, but let me think instead what's happened. That trauma-informed communication slide has some useful suggestions. Prioritize safety, 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 because you want people to be able to open up that prefrontal cortex and not stay stuck in survival mode. And then lastly, I think it's invaluable for us ourselves to understand our own stories and how our own lives have been shaped and impacted by trauma. And a lot of times, people kind of resist this because it means looking at really painful things. What I'm not saying here is that we need to, lift up the rock altogether or pull off the scab at one time, but recognize that bit by bit, we can, with support, with therapy, with a sense of self-efficacy and autonomy, we can heal. I'll close with a quote that's one of my favorite, that's attributed to Frederick Douglass. He said that it's easier to build strong children than to repair broken men. Thank you so much. If you've stuck with me, I know I've gone over, but thank you for your time and attention. If you have any questions, please don't hesitate to reach out. There's my email right there. Be happy to connect with you. And if you have an audience that you feel would benefit from hearing this talk, please reach out and we'll make it happen. But thanks so much. I do appreciate your time. Have a wonderful day.